right now, I'd like to introduce our Vice Chancellor of Diversity and Outreach, Dr. Renee Navarro.
Barbara didn't introduce herself. Barbara Sanchez is the Director of Communications for the Office of Diversity and Outreach. Thank you so much, Barbara. Thank you all for being here today. I'm really excited to be here. Good morning. Welcome. Today is our 16th annual UCSF Health, Equity, and Anti-Racism Research Symposium, known as HERE. We're here to listen and learn and apply our knowledge. I'm Dr. Renee Navarro, she, her pronouns, and I serve as the Vice Chancellor for Diversity and Outreach. I'm also a professor of anesthesiology and perioperative care. So before we start today's program, we would like to start with an acknowledgement of the Ramaytush Ohlone people. We should have a slide to reflect. The Ramaytush Ohlone people, who are the traditional custodians of this land, we pay our respects to the Ramaytush Ohlone elders, past, present, and future, who called this place, the land that UCSF sits upon, their home. We are proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone elders, community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. The Office of Diversity and Outreach is also currently working on an acknowledgement of labor. While it's not finalized, we'd like to share our labor acknowledgement for you, and you can provide for us comments about this. We recognize that our country has been built on the labor of people from the African continent who were kidnapped, brought to the United States, and enslaved. We honor the significant contributions that people of African descent have made to this country, particularly in the fields of medicine and science. The wealth of this nation is indebted to their labor, bodies, and minds, and those from other historically marginalized people and groups over the course of our nation's history. We also acknowledge immigrant labor, including involuntary, trafficked, forced, and undocumented peoples who contribute to the building of the country and continue to serve within our labor force. We understand that while the goal of health equity is inclusive of all communities, it cannot be achieved without explicit recognition and reconciliation of the fundamental injustices of genocide and forced labor. We have adapted language for our labor acknowledgements from the AAMC and Seattle colleges. Please send us your feedback to this statement. Now about today. As I said, this is the 16th year of holding the symposium, but only the second year for the new name. In the past, we were known as the Health Disparities Research Symposium. 2 years ago, the planning committee and I collectively agreed that we needed to change the name to reflect the current need, the current moment, and to more accurately reflect the focus of the research presented here. So, health equity and anti-racism. In other good news, this is our first in-person HERE symposium since the start of the pandemic, and it's fantastic to be together, sharing our work, exchanging ideas, building community in person again. HERE showcases an impressive range of health equity and anti-racism research from scholars across UCSF, providing us with the opportunity to learn from each other, make connections, and share common goals. The research presented at this symposium demonstrates the very best of the scholarly rigor in service of both UCSF's mission to advance health worldwide and UCSF's commitment to health equity and anti-racism. This is always a wonderful learning experience, and I hope everyone can stay for the full program and also take time to engage with the posters that are going to be in the other room and our poster presenters. Now I'd like to introduce Dr. Tung Nguyen, our new Associate Vice Chancellor of Research, Inclusion, Diversity, Equity, and Anti-Racism. Just hold on. Dr. Nguyen is a longtime partner of our office and a long-timer co-leader, co-conspirator in terms of moving the needle on diversity, equity, and inclusion and anti-racism in research. He and my two other long-term collaborators, co-conspirators, Drs. Victor Fujimoto and Dr. Jane Ji, contribute their time and share their expertise year after year to make this symposium happen. We couldn't hold this symposium without the leadership, with their leadership. Thank you, Tung, Vic, and Jane. I'd also like to extend my gratitude to the other folks who come together and make the HERE Symposium possible. The faculty who assisted with the reviews of the abstracts and the posters. Your work is crucial and we really appreciate it. Just as importantly, I'd like to thank the ODO team, and in particular, Angelin Rivera and Brooks Beigert. And I'm sure they're out there at the desk, but they have done months and months of hard work to make this happen. Thank you also to all of the presenters whose commitment to equity in research, patient care, and access is critical to progress. Thanks to all of you for being here, for your engagement and your participation. I hope that you'll find the research shared here as illuminating and inspirational as I do. Please enjoy the symposium today. And now, Dr. Nguyen.
Okay, good morning. Tung Nguyen, Professor of Medicine, Associate Vice Chancellor for Research, Inclusion, Diversity, Equity, and Anti-Racism, or IDEA, so that when they ask you what's the big idea, it's inclusion, diversity, equity, and anti-racism. Welcome to our first back-in-person symposium. I just wanted to say we appreciate you being here. Second of all, we had 300 people sign up. We actually had to close registration, so I'm hoping that this is people just figuring out how to get here, and also going back in person. I do want to encourage you all to stay here. I know it's difficult to be here the whole day, but to be here for as long as you can. Partly because I think we have a great program with a lot of really good innovative stuff that I think will make a difference in your own work, but partly because also community building is part of equity and anti-racism. I actually think that people sometimes think community engagement is optional in research, and maybe it is for some people and maybe it isn't, but certainly when you do equity and anti-racism research, it is absolutely essential. And I'll say a little bit more about that later when I give my keynote today. But as Dr. Navarro said, we want to thank our selection committee. This kind of conference does not go off without the contribution of dozens, if not hundreds of people. And these are the people on our selection committee for the posters and the oral. You meet some of them today as moderator. We also obviously want to thank Dr. Navarro for making this symposium possible. The faculty lead she's mentioned, and also Dr. Alejandro Rincon as well. And then we also mentioned the staff, because I think it's important. Again, most of this work is done by our staff. And I actually wanted them to be in the room. Terry's back there. Aria's back there. Brooks has completely disappeared. Here she comes. Brooks Bigard. And Angelin Rivera, who ran this show for many years, is always never in the room when we want to thank her. Okay. All right. We obviously also need sponsors, including people who help us put this on. And this is the list of the organizations. I'm really proud that this list gets bigger every year because it indicates of the amount of this kind of work that's going on at UCSF. And our champion sponsors, thank you for your work as well as the financial contributions. One quick thing for those of you who either have been trainees or are trainee, NIH Diversity Supplement is a great way to get people who are underrepresented into research. We have a mechanism set up to do this. For those who are actually planning to apply this year, there's some new sort of logistical things. And Arya Yao is the person you should email for any questions. We also have a diversity supplement matchmaking program that goes off every year in January or February. So keep an eye out for that if you have an eligible grant or if you're interested in participating as a trainee or early career faculty. So without further ado, we're going to go into the oral presentations. I'll start by introducing the moderator. I do want to emphasize to all the presenters that we are sticking by the 10-minute time limit, partly because we have a packed agenda, but also because we want to be respectful of the people who come after us and not take up their time. At about 1 minute, we'll let you know, and then you should just wrap it up. And so it's my pleasure to introduce Dr. Sharon Humans, PharmD, a clinical pharmacist, but also the Executive Vice Dean of the School of Pharmacy. Dr. Humans.
Good morning, everyone, and again, welcome to the symposium. We're very, very excited, and we want to get underway right away with our first group of presenters. So I will call their names up, and they will come up to the podium before they give their presentations. And I also invite you all to really come up with some good questions. We'll have a Q&A for about 10 minutes, so please don't make me ask all the questions. So I'm sure something will come up that will either need clarification or you might want to hear a little bit more of. So our first speakers this morning is Maria Contreras-Oseguera and Edgar Castellanos. And I invite them to come to the podium. See. We also have Grace Hildebrand. We might need another chair because there's 5. We want them all to be up here, right? So they can go boom, boom, boom. Go ahead. Grace Hildebrand, Nainika Palmer, and Deandra Lee. So Maria and Edgar will begin our presentation, and thank you very much. And we look forward to hearing the great, exciting works that all of you are doing. So please go ahead.
Do we just click? Sorry, my apologies. Thank you so much. Appreciate you. So, good morning, everyone. We'll get started just for the sake of time. But yeah, let's dive into some background. So as we know, inadequate healthcare coverage impedes healthcare access and fuels health inequities. The proportion of Latinx people who are uninsured is alarmingly high within the United States, with 21% reporting that they do not have health insurance. When looking at our white counterparts, only 7% reported this. We see this also locally in the Bay Area, where 9.4% of Latinos reported being uninsured. And once again, when comparing to white people, only 2.9% reported this. We know that structural barriers drive inequities in the Latino community, but perhaps community-based navigation by community health workers has the potential to improve linkage to insurance and primary care. So the question is, can community-based COVID-19 test sites, which were designed to circumvent many of these structural barriers, be used? And not only be used as an infrastructure, but also be leveraged to link people to care. So an example of this is here in the Mission District with Unidos en Salud, which have been able to provide over 120,000 COVID tests and more than 72,000 vaccines. And much of this success has been due to their low barrier site component, which means language concordance services and education are present, and much more important, trust and convenience is established in community. And it is in here where a lot of community members were sharing with us that they did not have access to healthcare due to lack of insurance. And we know that we couldn't just sit down and do nothing. So our response was creating Caminos. So what is Caminos? Caminos is a community-based linkage and health navigation service here in Unidos en Salud. And I want to point out that some of our awesome team members are in the audience, so big shout out to them. So Don Jose and Deanne Jones. Thank you. And also, this presentation has 2 phases, but we're only going to be focused on phase 1, which is our on-site referral to Healthy San Francisco using a web-based form. I want to also note that this corporation of it was established first through the efforts of Maria Contreras and also the student-run free clinic in Clínica Martín Barro. So diving into its study objectives, number 1, we wanted to characterize the people that were visiting our site between those insured and uninsured. And 2, we wanted to assess the referral system that we had, whether or not how many people linked to care and what were the barriers. So objective 1, our study setting was we did a cross-sectional analysis of participants between the dates of January 2022 to February 2023. Our primary outcomes were self-reported status of insurance between 2 points of entry when a vaccine registration and testing registration, and a logistic regression model was used in order to see the relationship between health insurance and demographic characteristics. So looking at results, we have a demographic table. I will only want to highlight 3 things. First, 81% of the individuals reported being Latino. 2, most people reported an annual income of less than $50,000. And 3, when it came to insurance, 42.6 said yes to insurance, and 32.6 said no. Now, when looking at our logistic regression model, our predictors of insurance indicated that all of these demographic characteristics had an impact. Nevertheless, I want to focus on race and ethnicity, where we saw, where we saw that 2.6 of our white counterparts had more of an opportunity to have health insurance than our Latino population.
So in our objective 2, we decided to assess, are we linking people to healthcare? And what are some of the barriers? For our study design, the green button. For our study design, we looked back to how many people we referred. And we had referred individuals from January 2022 to February 2023 using Healthy San Francisco nested within a United and Health vaccine testing site. We set our goal to target 50 participants, and with the goal of reaching the Latinx population, and in addition to measuring how many people actually linked to a healthcare home, had insurance, and had access to a PCP. In addition to that, we also wanted to categorize the barriers that our community faced through migration-related barriers, language, and logistical barriers. So overall, since we nested our Healthy SF referral, we were able to refer 716 people from September 2022 to February 2023. You can see that we randomized and selected 147 people, and we actually got a hold of 52 people who actually did the survey and completed the questionnaire. What you're seeing here are the general demographics of our population that we targeted. And you can see that 100% of the population that we served and targeted were identified as Latino. You can also see that 98% of the individuals that were in our subset sample, 98% of them preferred Spanish as their language. Another thing that I really want to highlight is that we have individuals who are coming from all different areas of the United States and outside of the United States. And I think that's one of the beautiful things in San Francisco. We're having folks coming from El Salvador, Mexico, Honduras, and we're also hitting our high target from individuals that come from zip code 94110. So overall, what proportion of people did we actually link through our referral system? You can see that 33% actually did link through our referral system, but 33% did not. 3.2 decided to decline. Now, out of those that linked, where were they getting their care? 18% said that they were getting their care from Healthy San Francisco, 18% Medi-Cal, and 24% private insurances. So out of the people that actually linked, we wanted to see, do you have access to a healthcare home? Do you have access to a primary care provider? 65% mentioned, yes, I do have a healthcare home. 53% mentioned, yes, I do have a primary care provider. 100% who did not have healthcare home, 56% who did not have a PCP, wanted Caminos to support with linkage. Now, what happened to the people that did not link? So people that did not link, 56% of them measured that they were unaware of the process, had barriers with language, getting a hold of a presentation. 63% did not have healthcare home, wanted Caminos to health insurance. And I'm highlighting here some of the things that we're dealing with our communities, the complexities of not having a healthcare, not having a social number, being able to not make the choice between having rent or paying for an insurance. Our limitations is that we did have individuals in our analysis that declined to tell us their status for insurance, but we decided to remove them, and our sample size being small. In general, the healthcare linkage coverage was high among our testing site. The Camino referral system did reach a high proportion of Latinos, like we set out to do. 1/3 of the people that participated in the program linked to the healthcare coverage. However, many continue to face barriers, including language barriers. And in addition, coupling navigation services can prove that we can actually link people to healthcare and home insurances. So where are we at right now? So Camino has been enhanced. We are providing navigation services. We have 36 individuals who are, again, 100% of them are Latino. And what's really interesting here is that when we asked individuals, do you have a prior health insurance? 81% said no. And so 78% also mentioned that they like assistance. The really also amazing other thing is that we have linked 32% of these individuals to care. And so with that, we want to highlight our PI, Dr. Marcus, who's here in the audience, along with our partners, UCSF, who's also funding this work, and highlight also the student advocacy. Advocacy is not done alone, it's done in collective efforts. And so with that, we thank you.
Hi, everybody. My name is Grace Hildebrand, and I'm a second-year medical student working with UCSF's Vouchers for Veggies team. And I'm very excited to be here today to share our re-aim evaluation of a community produce prescription program for low-income households. So some background. It's well documented that food insecurity adversely affects physical and mental health through multiple pathways. And interventions that simultaneously support food security and diet quality have recently gained momentum. Produce prescription programs are one such intervention that provide individuals and families with prescriptions for fruits and vegetables with the goal of reducing health disparities by offsetting financial barriers to accessing healthy foods. So our study aimed to evaluate the implementation and public health impact of UCSF's Vouchers for Veggies Produce Prescription Program, also called V4V. And we do this using the RE-AIM framework, which stands for the Reach, Effectiveness, Adoption, Implementation, and Maintenance. So this framework addresses 5 dimensions of a program, from its impact on individuals to examining the context and settings in which the program is implemented. So Vouchers for Veggies. This is a produce prescription program that was started by Dr. Hilary Seligman in 2015. And at a basic level, it works by participants enrolling in the program through a partnering community organization where they receive vouchers each month that can be redeemed for fruits and vegetables at partnering vendors like grocery stores. Going into more details, our distribution partners that distribute vouchers include clinics, supportive housing sites, senior centers, family resource centers, and WIC, and our vendor locations include grocery stores, corner stores, and farmers markets. Eligibility broadly includes individuals that are low income and at risk for food insecurity, but it's not prescriptive and really depends on the priority population of our partnering organizations. And our partners enroll older adults, pregnant people, families, BIPOC individuals, and people living with chronic disease. Households of 1 to 2 get $20 per month, and households of 3 or more get $40 per month. And vouchers are given for 6 months. And this evaluation focuses on the program in San Francisco, but it's also expanded to other California counties and other states. So briefly going into methods, we conducted a retrospective analysis of data collected for program implementation and quality improvement between January 2015 and June 2020. And our primary data comes from surveys of participants, which were pre-post and collected on program outcomes and satisfaction, and from cross-sectional surveys of our vendors and distribution partners. And so this brings us to REACH. Which is our first section of our results. So we calculated REACH by determining the number of individuals who were enrolled in the program compared to the number of people that could have been eligible for the program. So between 2015 and 2020, V4V reached 10% of San Francisco's households living at or below 200% federal poverty level. So the bars on this graph reflect the REACH each year of program operation, and the line shows the cumulative program REACH, and you can see that in 2015, we reached 0.68% of the priority population, and by 2019, in that year alone, we reached almost 4% of the priority population, with the cumulative reach at that point being 8.59%. And this growth in the program is largely attributed to increases in funding. Program data collection stopped for this evaluation in June of 2020, but the program is continuing today. So the other aspect of REACH is the representativeness of program participants. We asked the question, does the program reach a population that reflects the total population who could be eligible? So we do this by assessing self-identified race and ethnicity of our participants as a proxy for their experiences of racism, since we know that food insecurity arises from structural racism along with other forms of oppression. So in the graph on the left, you can see that green reflects the breakdown of our V4V participants, and blue reflects the breakdown of San Franciscans living at or below 200% federal poverty level. And from this, you can see that we reached a higher proportion of individuals identifying as Black or African American compared to San Franciscans living at or below 200% federal poverty level. And this reflects V4V's partnership with community-based organizations that specifically serve Black individuals. And the rest of the slide shows other sociodemographic characteristics of our participants. And note that 94% of the sample has a monthly income less than $2,000 a month. So our measures of effectiveness were self-reported health, food insecurity, and fruit and vegetable consumption. If you look at the graph on the left, you can see that 40% of our respondents improved by one or more category of self-reported health from pre to post. And the graph on the right shows improvements in mean food security, with most of this improvement coming from individuals moving out of very low food security and into higher categories of food security. And finally, if you look at the purple box, you can see that mean fruit and vegetable consumption improved by 0.77 servings per day. And all of our results were statistically significant. So this brings us to adoption, which measures the total number of organizations that adopted the program. And over 5 years, we partnered with 135 distribution partners across San Francisco, most of which were supportive housing sites and clinics. And we also partnered with 29 vendors, including 4 large grocery stores, 23 mid-sized markets and corner stores, and 2 farmers markets. So implementation assesses our partners' fidelity to the program design and operations, along with their barriers and facilitators to implementing in different settings. And we use cross-sectional surveys of vendors and distribution partners for this slide, or for this section. And largely we saw that vendors and distribution partners were satisfied with the program and found it easy to use. Our vendors reported an increase in fruit and vegetable sales, an increase in income, and an increase in their customer base. And our distribution partners found that V4V was a helpful resource for their clients. In terms of barriers, some vendors reported that it was time-consuming to accept vouchers at the register and that there was a long wait time for voucher reimbursement. And from our distribution partners, some reported that it was time-consuming to enroll participants, and some had challenges with pre-post survey administration. And this feedback has led to some iterative changes in our program design. And we also collected data on participant feedback. Our participants were satisfied and agreed the vouchers were easy to redeem. 63% agreed the voucher amount was just right, while 31% reported the voucher amounts were too low. So that brings us to the final dimension of the REAIM framework, which is maintenance. And this measures how the program impact is maintained 6 months or more after program completion and to what extent the program becomes institutionalized. So after program completion, participants reported changed perceptions about fruits and vegetables, but financial barriers to maintaining fruit and vegetable consumption. For distribution partners, they have stayed with V4V, with 50% having worked with our organization for 1 year or more at the time they were surveyed. Some distribution partners also requested to extend the program length. And vendors also stay with V4V once onboarded. And we found that V4V may have a lasting impact on their customer base, especially for the smaller markets and corner stores. On the programmatic side, sustainability of funding is essential. V4V does have ongoing funding, but limited multi-year contracts, which can cause disruptions in service delivery. There are also 300 plus organizations on a wait list to partner with V4V. So growth is limited by funding and not by demand or interest in the program. So in conclusion, V4V has potential for high public health impact based on the dimensions of the REAIM framework. We found it had broad and representative program reach, and that it was effective in a pre-post study, which is consistent with more rigorous evaluations of similar program models. V4V is also scalable, with implementation considered easy across multiple settings. And aside from our evaluation focused on San Francisco, this model has expanded across the United States. So there's policy momentum right now to fund and scale up produce prescription programs, but additional studies are needed to determine best practices. Thank you very much, and thank you to my team and to our funders.
Good morning, everyone. Green, thank you. All right, I'm going to share a project that I worked on with my team called Here with Community, Health Equity COVID-19 Research with Community Health Centers. I want to acknowledge my study team, including Dr. James Harrison, who's my co-PI, Dr. Mike Potter, and Saji Mansour, along with our community advisors, some of which are here, so thank you for showing up, and our study site collaborators, including Benioff Children's Hospital, Oakland, Family Healthcare Network in Fresno, and the UCSF Fresno and the San Francisco Community Clinic Consortium, and of course the UCSF TTSI. As I mentioned, we were funded by PCORI. Just to give a little bit of background, community health centers, including federally qualified health centers, deliver primary care to the most socioeconomically disadvantaged, including disproportionate numbers of minority, racial, and ethnic immigrant populations. Unfortunately, engaging CHCs and communities they serve and partner to research remains very uncommon and challenging in a lot of ways, which I'll go over. So what we wanted to do is identify those challenges and also elicit recommendations to support research and community health center partnerships and figure out ways we might be able to create infrastructure and resources to facilitate this. We had an advisory board of 11 board members from all of our site participants, our site collaborators. We met every 2 months, and this group of advisors informed our project activities along with various input, including, after we got started, wanting us to go to the Central Valley to actually put more emphasis and focus on farm workers. So that actually was added onto our project after actually receiving funding. We conducted 21 focus groups with 44 participants from BCH Oakland, in Fresno, in San Francisco, and the UCSF CTSI community, and as I mentioned, the Central Valley community leaders, along with farm workers in the Central Valley. After conducting these focus groups, we presented some preliminary results at the SF-based CRN, and then had breakout sections to actually give feedback to get feedback from the participants on some of the findings that we had, including COVID-19 priorities. We also revisited some of our members in the Central Valley area and did some member checking. So I just want to orient you to the results that what I'm going to share is a lot of information, but also in a shorter period of time, but also covers several different levels, including policy, CHC academic partnerships, individual organizations, and then the interpersonal relationship between CHCs and researchers, and then of course education and training components that we want to cover. So one of the greatest issues that was brought up amongst our focus group participants was that research is not a priority for CHCs, which is not surprising, and academic models just don't apply to CHCs. And so one important quote was, the bottom line, federally qualified health centers are underfunded, understaffed, and everyone's overworked. That's the baseline. Research is not a big priority. More importantly, there's just not infrastructure to support it. So some suggestions that came up were to try to create a shared equity-focused strategic research plan so that we get rid of this idea that researchers can come in with whatever research question they have, but rather build the research agenda with the partners you want to work with. Additionally, some ideas that came up were supporting an FTE for dedicated staff that actually is focused on research, because the staff that's there are just not hired to do that. Additionally, there's this limited existing relationships and lack of trust between community health centers and academic medical centers. And some of this, relates to the fact that, essentially the relationships are built on individuals versus institutions. And so it really becomes like who I know and who I want to work with versus having a true partnership across institutions. And so some suggestions that were brought up were having systematic and ongoing engagement between senior leadership of UCSF and community health centers regarding agreements and how we would engage in research and other partnerships to actually meet the needs of everyone and not just research agenda. Some other ideas that came up was raising bidirectional awareness of CTSI resources and programs that could be made available to CHCs, and also creating opportunities for CHCs to leverage academic centers' infrastructure, perhaps being able to support real-time data collection and clinical expertise to support their programs. Communities also lack relationships and trust with academic medical centers and CHCs. Again, none of this is really new information, but it really just pushes home the point that there needs to be more trust building and addressing the issue of mistrust, so undoing what mistrust was developed. And that this doesn't just come from the perspective of historical context, but contemporary lived experiences of our community members and our community partners. So some suggestions around that was, again, bringing up having a more systematic and ongoing engagement to actually build research agendas together versus bringing an idea forward, and improving community engagement to hear about what the healthcare and research needs are. So going to them to see what they would like pushed forward versus us coming to various entities to say, this is what research idea we have. CHCs lack infrastructure and expertise to conduct research, write grants to be able to even access research funds. And so there's a lot of opportunity here to connect resources such as the CTSI programs and resources with community health centers that we might want to work with. And also perhaps figuring out, is there a centralized person or resource point between both academia and CHCs that can make that research connection between the entities. And again, building this infrastructure that may actually help support conducting research, whether it's hiring someone or identifying someone that's specifically about data analyst or a QI person within the clinic who can help. Academia initiated research does not match the priorities of CHCs or the communities. And so here, this again just highlights the fact that research that's being done, or when a community is asked to do research, it's the agenda of the researcher versus agendas that came forth from the community or the community partners you want to work with. So, for example, we should be going to CHCs and finding out what they would like to do to help improve patient care amongst their populations, and going to community members who are served by those clinics to figure out what's really important to them. Another big point was to improve the clinical partnerships between CHCs and academia to support research. So one example is a quote noting that I may be overgeneralizing, but when it comes to this clinic working together with UCSF, we're always very happy with the inpatient service and what we're able to do for our patients when they are there or admitted. But kind of these things are discharged, or once they're discharged, they're back in my hands. So there's this aversion of Medi-Cal patients. And so we really need to have some better partnership between the community health centers and academic medical centers to ensure patients are getting the care that they need, not just for inpatient services, but outpatient services as well. So going back to my original point, that our advisors really pushed us to go into the Central Valley to really address what's going on with farm workers. We actually did a visit down to the Central Valley, met with numerous farm workers and community organizations, and some of the things that highlighted are going to be a little bit repetitive, but I think it drives home the point that there are still lots of issues out there. Specifically improving the access to healthcare, like this is clearly still an issue. And I just want to note that while this was project was focused on COVID, you are noticing the topics are not just COVID related, like this really just goes across the healthcare institutions and the climate of our healthcare system in general. There's also a need to increase awareness about resources for community health centers that academia can offer to the communities, that community health centers and academia can offer to the communities. And again, driving home this point of conducting research that actually matters and that is relevant to the community members that we serve. And building meaningful relationships and partnerships between community members and for example, going out to the community and doing presentations or things that they want to do versus, hey, I'm doing this research study, who can I talk to, getting connected to that person, and you're just coming in to take. So in that vein, one of the comments that we got on our first visit was, we want you to return. And we listened to that. And when we came back to do our final presentation, or at least to share results and to do some member checking, they noted to us that we're the only ones who had come to actually give back results. So think about that. How long have we been doing community engaged research? And we were the first ones in this community to come back to share results. And I think that's just a horrible situation that we're dealing with, and that we should stop this helicopter dropping in research and actually try to build better relationships and partnerships moving forward. I just want to thank our advisory board members. These are some of the ones who attended during the SF-based CRN, and thank you to those who showed up today. I really appreciate it.
Good morning, everyone. My name is Deandra Lee. I use she, her, aya pronouns. And I'm the Racial Equity and Health Senior Community Health Planner at San Mateo County Health Division of Public Health Policy and Planning. And today I have the privilege of representing our Public Health Division and sharing our community-informed research approach for the development of a community collaborative structure within public health governance. We all know that the COVID-19 pandemic called attention to long-existing racial, ethnic, and socioeconomic disparities in health outcomes. Specifically, in San Mateo County, research during the pandemic identified a disproportionate burden of COVID-19 infection and death amongst Latinx and Pacific Islander communities. Because there wasn't already a formal structure in place for community collaboration, the San Mateo County Public Health Division struggled to quickly respond to the needs of the community and include the community voice in the strategies for COVID mitigation and control. We know that the community is aware of the historical and current power imbalances that reinforce health inequities. This awareness requires a shift in the purpose of community engagement to support community power building. To advance our commitment to health equity and improve health outcomes for all members in San Mateo County, the San Mateo County Health Division of Public Health Policy and Planning, which from now on I'll refer to as PHPP, developed a community collaboration process to identify and implement a structure for authentic community collaboration within PHPP. The community collaboration process, or CCP for short, had two aims. The first, to develop a structure where the public health department and community members could collaborate on equity activities, surface priority community needs and strategies to address those needs, and provide mechanisms for accountability. The second aim was to develop a free community health equity resource to equip our community members to be able to fully participate in the newly designed structure. As part of this process, we first conducted a literature review on existing community engagement frameworks. This was followed by interviews with 6 jurisdictions in our region to understand any model best practices that we could adapt. Then we interviewed our internal PHPP managers to understand our baseline processes for community engagement. To ensure that this process reflected the true needs of the community, a 10-member working group of community leaders and representatives was formed to guide and inform the process. Working group members were carefully selected to represent the diversity in our county in terms of geographic location and demographics. This working group helped to solidify our aims, provided input into the community presentations and the questions we asked, and more. Participants of the working group were paid a stipend for their time and expertise. From the working group's direction, we engaged different community groups for the input sessions to invite community to decide what structure for collaboration with PHPP would work best for them. The groups were also carefully selected to ensure that all priority groups in terms of race and ethnicity, gender identity, age, faith, and geographical locations were included, using purposive sampling methods paired with snowball sampling. During these sessions, committee members were asked 4 questions to help us co-design the project's aims. Participants were compensated for their time, and we analyzed the data using a thematic approach. Through the input sessions, we engaged 354 community residents across 28 different groups and organizations. We covered a wide geographical range across San Mateo County as shown on the map. Notably, our demographic reach was reflective of our county's total racial and ethnic makeup, and we intentionally oversampled the priority marginalized communities. Building trust is essential to authentic community collaboration. Therefore, we asked community for ways in which PHPP could build trust with them. There were 5 major themes that arose from this data. These included engaging and being present in the community, consistent, transparent, and honest communication, enforcing anti-racist practices, diversifying staff and employees, and consistent access to health education. Some quotes from the community that highlight this include, keep being involved in the community. Even if public health is ready to move on, sometimes the community isn't ready. And make only promises you can keep. And build partnerships. Information presented to the community should include language vernacular identified by the community. In response to the first aim to develop and implement a community collaboration structure, we asked the community what an ideal structure for co-creation and shared decision-making with PHPP would look like. Of the 378 responses, the majority of the community preferred that PHPP develop a strategic plan and that the structure be community-run. From this data, we were able to make 5 recommendations for a structure. Of the 5 recommendations made, our PHPP leadership committed to implementing the top 2, a community collaborative structure led by a local community-based organization, El Concilio de San Mateo, and we're currently in the process of completing our first ever PHPP strategic plan, where community groups and members are involved in this process. In response to the second aim, to identify and implement a community-facing health equity resource, we asked the community what topics they were interested in learning about. 6 major themes arose from this data, the top 2 being resource navigation and public health topics. In response to this, we are implementing a free Public Health 101 workshop that will be launching early next year. This workshop will be paired with a 5-minute video and a handout to educate community members about the role of public health and how they can influence health in their communities. This is what power sharing in action looks like. When the community makes an ask, we respond and we implement. And we're also very honest about what we have the power to change. The CCP ensured that community was engaged throughout the process, not just in the design, but also in the results and in the next steps. Some examples of this, in partnership with our community partners and our working group members, we developed a proposal that had 5 recommendations for a structure and 5 recommendations for how to build trust within that structure. Additionally, in effort to practice transparent, honest, and consistent communication as called out by our communities, we developed an in-language and culturally relevant data summary of the proposal and findings, and paired this with follow-up presentations to each of the 28 groups we initially gathered input from in the first place. During these follow-up sessions, the communities were given the chance to inform our next steps. And finally, based on the data from the follow-up sessions, the working group members developed evaluation metrics and negotiated with our PHPP leadership around their commitment to the recommendations that were made in the proposal. Some of these recommendations, as I've shared, have already been implemented or are in the process of implementation. Equitable community engagement requires ensuring that those most negatively impacted by inequities have a chance to participate in the development and implementation of solutions. Therefore, to achieve the mission of health equity, we must design more community-centered decision-making processes that widen the range of the people and the communities involved in efforts to reduce inequities. As research institutions and government entities, we must be honest with our power and reconcile with the history of our institutions and the community harms inflicted. We must utilize trust-building mechanisms to ensure authentic community collaboration and work towards community healing and repair. Community collaborative structures must also be community-informed and/or community-led to ensure equitable power sharing. And finally, government institutions must co-design structures for community collaboration. For example, community engagement toolkits and frameworks must be co-created with community. Extra effort and capacity will be necessary for this work, but when we are willing to stretch, we get closer to moving at the speed of community trust. Thank you.
So on behalf of the audience, I wish to thank all of you for your wonderful presentations and exciting projects and wonderful, important work that is going on. And I love the community engagement piece because we have to do this together. In academia, we don't have all the answers. So we have about 6 or 7 minutes for Q&A. So we do have a roaming microphone, wonderful. So excellent. So whoever has a question, please stand, give your name, and direct your question to who you would like to answer, and thank you.
Hi, Barbara Sanchez. I work at the Office of Diversity and Outreach. My question is for Deandra. I'm curious how exactly the community members are involved in developing the strategic plan and if they're compensated.
Yes, so does this work? Can you hear me? Okay. So we're currently in the process of this strategic plan, and right now we're implementing some community health forums. So we're having a couple of community health forums across San Mateo County, and in these sessions we're sharing some data around what the health needs are across San Mateo County, but also asking the community what their prioritized health needs are. So this is the first step to that. They are being compensated for this time that they attend the forums. They receive about a $25 gift card, and we also provide food for the forums. So like I said, this is the first step. The second step will be developing a community health improvement plan that will then feed into our PHPP strategic plan. And community members will be involved throughout the process, and as I said, compensated for their time in that way.
Thank you. Next question. Oh, go ahead. I don't know if we could turn up the microphones in the audience because I'm having difficulty hearing. No, we can't hear. Liz, we can't hear you.
Okay, hi, that's
perfect.
better. Thank
Yes.
you. Thank you for those great presentations. I'm Elizabeth Ozer, and I had a question about the first one, Maria and Edgar. May have been on the slide, which was a little hard to see with the light, but when you talked about the insurance as well as the access to care, were there differences in age groups in terms of your population, in terms of young adults or older adults, et cetera? Thanks so much.
It's not on.
That's a great question. Right now, we haven't stratified our analysis by age group, but we are serving a population that's 26 to 49 years of age. And so if many, which, these are the restrictions also for Medi-Cal. Right now, if you're undocumented and fall within these age ranges, you don't qualify for full scope Medi-Cal, rather restriction. And so there's luckily San Francisco has Healthy San Francisco, which it's a program that you have to pay. So that's one of the options that we navigate with our community members.
Good morning. Thank you to all the presenters. This question is for Deandra Lee. Can you cite one example of the trust-building mechanisms that you instituted?
So one of the biggest trust building mechanisms that community identified was that we follow up. And so, similar themes across my colleague here, but we made sure that we presented back our findings and we continued that relationship with them. So even though after we did a follow-up session with them, they were, very happy to see us, because at times we don't follow up, right, with community. We go in, we ask them for things, and then we never return. So we followed up with them, but then we're also continuously building up our relationship with them. We've asked them to send us, anytime that they're having a community event where we can attend. So we have our staff intentionally go to those events, be in their community meeting spaces, just so that we can become a friendly face and that we can build that relationship with them. And for them, that was one of the most important things, was making sure that we are actually in community with them for the long run and not just for the short term.
Great.
Hi, this is really loud. I'm Maja Jackson-Trish, and I wanted to thank you for all of your really interesting presentations, and would like to get your response to, the more I'm thinking about it, we're talking about research, is that we have to shift the whole paradigm about how we talk about research and even using that kind of word, because it still is kind of a colonial approach to dealing with people. Someone's being researched and someone's making a career or whatever. So I would like to challenge us to rethink what we mean about it and the kind of language that we use, and how we've structured ways that kind of exploit people a little bit. And I've been a health services researcher, and I've done community participatory research, and it's troubling, but I think this is encouraging.
So just quickly, hi, I'm Hal Collard. I'm a faculty member here. Thank you for that comment, by the way. I also serve as Vice Chancellor for Research, and language is so important, and I'm listening a lot here this morning. Grace, I wanted to just ask you if you could quickly comment about your bullet point about policy moving towards supporting your your work or your results. That's such an important next step to a lot of the work we do. Could you just comment a little bit on what you're seeing and maybe how you're engaging?
This is on. Great. Thank you for your question. Yeah, there's a lot of, so produce prescription programs are a pretty recent intervention, and they're gaining attention at the national policy level. So there was a White House conference on food, hunger, and health, I don't remember the exact name, where they featured produce prescriptions as one solution to food insecurity. So there's interest in funding through USDA, but also in the healthcare setting, there is interest in getting sustainable funding through the Center for Medicaid and Medicare Services for produce prescriptions in that setting.
Hi, thank you. Your guys' presentations are absolutely lovely. My name's Allie, and this question's for Grace. I'm just wondering if you could clarify. I'm over here.
I'm sorry, I was going to ask you to stand up. I'm like, where's that voice coming from?
I'm just wondering if you can clarify how V4V interacts with CalFresh and EBT, and whether being part of one disqualifies you for the other, or maybe makes you automatically qualify for the other.
So that's a great question. Right now, V4V is an additional supplement to existing food resources, and it doesn't disqualify you for food resources you may qualify for. We also specifically partner with WIC. So when individuals are enrolling at WIC offices or clinics, then they can get V4V vouchers there. So it's an additional benefit at the moment.
Well, thank you very much. I'm sorry to have to cut us off, but our next session is going to start with the posters. So let's give another round of applause for our presenters.